Okay, I will get started. Zoom is always a little tough because I tend to dislike lectures and prefer engagement. So please feel free to either unmute and ask questions as we go along or type in the chat. I'm going to try to keep the chat open if I can. And I hopefully will break up a few things and would love it if you guys would type in the chat when I do ask questions. So I'll start with just learning objectives. I talk about hemoptysis with the pulmonary critical care fellows, obviously. And I think that, when it comes to core topics for internal medicine, this isn't always at the top of the list, but I think one that is scary and common enough that you guys will see in your practice. So I'm going to, for learning objectives, we're going to review some definitions, really understand the role of diagnostic studies, describe various methods to control bleeding, and just talk about how we apply a multidisciplinary approach to the management of these patients. So just a few refreshers, a little anatomy refresher. Hopefully you all remember that there are two circulations in the lung. So there are the pulmonary arteries, which are a very low resistance system with thin walls. They travel along with your airways, and they really serve as the primary feeding arteries to your alveoli. So they kind of come together and really feed capillaries into all of your airways and your lungs. So that's your pulmonary arterial system, which is really low resistance and low pressure. Then you have your bronchial artery system. This comes off of your aorta, so it is a high pressure system. And the bronchial artery system is primarily responsible for vascularizing your lymph nodes, your mediastinum, your larger airways. They have these little perforating vessels that kind of go into the muscular wall of the bronchi and feed them there. So it's important to understand about these two different systems, because as we, really get into the pathophysiology of hemoptysis, it's important to understand why the majority of patients who have hemoptysis, why that blood is actually coming from the bronchial system, which is the high pressure system. So almost 90% of the time it's coming from that system and not the pulmonary arterial system. And the way I think about it, in a lot of the patients that you probably will see that have submassive hemoptysis, these are patients who present with bronchitis, they have bronchiectasis, maybe pneumonia, TB. These are all patients who have some reason to have chronic inflammation or infection. Over time, that inflammation really leads to pathologic alteration in the bronchial arteries. They become more friable. Some of them develop pseudoaneurysms. They can be distended, enlarged, and tortuous. There's really, great views of this if these patients end up getting an arteriogram from IR. You can see tons of collaterals and a lot of tortuosity. So especially in some of these patients who maybe have some kind of chronic cavitary disease where it's really developed over a long period of time. So when all of that happens, those vessels that are under high pressure and are then distended, have pseudoaneurysms, are prone to bleed, of course, burst and bleed. When we think a little bit about all of the causes of hemoptysis, like many sort of common symptom-based disorders, the list is long, right? So if you look at all possible causes of hemoptysis, I think of it a lot as, where is it coming from? So is it coming from an airway lesion? So airway lesions, you think about malignancies, you think about things that might affect the big airways, like certain types of collagen vascular disease, infections as well. So those are all common airway related diseases. As you get to the lower airways, you think about bronchitis, bronchiectasis, chronic infections that might be in that area. Is it a heme problem? So is this a patient with a coagulopathy? They don't necessarily have underlying pulmonary pathology, but they're more likely to bleed, and they happen to bleed in their lungs. Is it a patient with a capillaritis? So usually we think about inflammatory capillaritis. So that's usually from some type of collagen vascular disease. And, you know, do they have some rare vascular abnormality, or did they have some trauma or some kind of procedure that was just done on them? So those are sort of how I think about all of these categories, but of course the list itself is very long. I think it's important to know what is most common. So when you look worldwide, tuberculosis is the most common cause of hemoptysis, whether it is massive or non-massive. And we'll talk a little bit more about the definitions of that. But really, tuberculosis worldwide. Then for massive hemoptysis, you're more likely to see a cause that is a bronchogenic carcinoma or a necrotizing pneumonia or a mycetoma, so an aspergilloma or something. Whereas non-massive tends to be after TB, bronchiectasis, acute and chronic bronchitis as the most common causes. So when we look more at developed countries like ours, so in the US, there is data from New York City, but it's quite old now in terms of causes of hemoptysis. France gets a little bit closer to our population mix to some degree. So they had a review that was about a decade ago looking at 15,000 admissions for hemoptysis. And in that group, the most common etiology was actually that it was cryptogenic. That's not that helpful, but only a small portion of those patients were eventually diagnosed with lung cancer. So it is at least reassuring. After that, infections, lung cancer, and bronchiectasis were really the most common causes. So here's where I want you to have your chats open, hopefully, and give me some of your thoughts. So let's imagine an epic chat. Hopefully this does not cause PTSD. So 2 a.m. epic chat from a floor nurse. Hi, this is a nurse for patient XYZ. Are you covering the patient? He just coughed up some blood. So what are you typing back to that nurse, you know, after seeing this message? So if you guys don't mind, just type into the Zoom chat, what is the information you want from that nurse immediately? Like, what are you going to type back? All right, awesome. Let's see if I can keep up with all of this. Okay, so we've got how much blood, a lot of people asking about the quantity, excellent. People wanting to know ABCs, yeah, so what are the vitals, how well are they breathing, how are they saturating? Excellent. I love Noor saying, I'm coming to assess the patient. Excellent to write that first. So can they breathe? And then great, people are getting at, are we sure it's actually from the lung? Maybe it's from somewhere else. So thinking about, you know, could it actually be hematemesis, or could it be epistaxis? Is there something else going on? Awesome. Okay, so everyone is thinking about going to see the patient immediately. So let's go through sort of an algorithm about how to approach. And really the first step is, as many of you already said in the chat, it's really about quantifying the amount, because the urgency of your evaluation is going to depend on that. So we're going to focus first on what is called life-threatening hemoptysis. In a lot of the literature, it's also been called massive hemoptysis. And then we're going to kind of go through the steps. Once we quantify the amount, we're going to go through some ABCs, how to, you know, gather relevant data, how to localize the bleed, and coming up with a multidisciplinary plan. So we're kind of going to go through all of these steps. So the first thing is quantifying the amount of bleeding. How much is too much? And what is really meant by life-threatening bleed? Like, how do we know that? So unfortunately, there is no clear answer. There's no consensus. When you look in all of the studies, you know, what is defined in studies as massive hemoptysis ranges anywhere from 100 cc's to a liter a day. So 100 cc's is like your TSA size bottle, right? So it's pretty small. A liter, you guys, I think, can all imagine what that looks like. So it's a huge variation to what kind of meets this definition. In terms of life-threatening, you know, I think it's thinking about who has at least 100 cc's in a day and also either has hemodynamic instability or airway compromise. In terms of quantification, patients are pretty unreliable. And the first few hours is actually so important to actually getting reliable data and understanding what they mean. So a patient might tell you, oh, I coughed up a cup of blood, but they're not actually talking about the measurement a cup, right? Very often they're just referring to whatever in their mind represents a cup. So really err on the side of monitoring them closely, even if they look good. And part of that monitoring is actually giving them a container to collect their hemoptysis in, so it actually can be quantified. And you really want to know in the first hour and the first couple hours, how much is there? More than 100 cc's, then we should be worried that this is something that is bleeding pretty fast. And when we look at kind of how it's been described, again, understanding the definition of massive hemoptysis is not clear, but using this wide variation, it represents about 5 to 15% of all cases of hemoptysis. So the vast majority of the cases of hemoptysis you see are not going to be life-threatening. But of course, in the hospital, you have to be prepared for that. So what is the risk of death in massive hemoptysis? Again, the variation is huge because people define it differently. So anywhere from 9 to 40%, depending on the case series that you look at. But what is the most common cause? I think when we think of bleeding in other areas like the GI tract, we think about hemorrhagic shock as what ultimately could lead to instability and death. But in hemoptysis, that's not the case. It takes very little blood to fill up your alveoli, cause asphyxiation and intractable hypoxemia. So it's really hypoxemia from that asphyxiation that leads to death in patients with hemoptysis, not exsanguination. It's important to realize that because it explains why we are so careful, even early on when somebody is completely stable, their respiratory status is stable, they seem awake, they can manage it. But because that can change very quickly, the second you fill up any alveoli with blood, that alveoli is no longer participating in gas exchange. You're not going to be able to reverse that quickly enough. So risk of death is associated with greater volumes of blood if they've already aspirated blood into their good lung, any patient who's requiring single lung ventilation, if the cause is related to cancer or aspergillosis, that increases mortality. And if in those rare cases, it's actually the pulmonary artery involved, that also has a higher risk of death. And then obviously patients with poor cardiopulmonary reserve, they can't handle, even a little bit of loss of their alveoli, are not going to tolerate it as well as somebody who's young and otherwise healthy. So I think first point for everyone to remember is that the greatest risk is alveolar filling of the uninvolved lung, leading to asphyxiation and intractable hypoxemia. So it's very important to keep that in mind, and why when we truly think somebody has a life-threatening bleed, we want to act quickly. So we're going to move on to the ABCs, which a lot of you brought up as well as something that you're going to want to think about in the first few minutes about hearing about this patient. Number one, you want to call for help. When you see the patient, if they're unconscious or they're in respiratory distress and they have hemoptysis, you just call for help, whether it's an RRT or an airway or whatever the code is, but you need people there. This is a patient who's going to need an airway right away, right? So when we think about airway in patients like this, we often think about how we can get the largest airway, with the largest diameter. Most of that is because we, one, need access often to either bronch or to try to stabilize that patient who's actively bleeding. Also because we may need to do single lung ventilation in a patient like this. And we'll talk about a couple of the airway maneuvers. This isn't that you guys are going to make these decisions, but so that you're aware about why some of the conversations that critical care and anesthesia might be having about how to manage a patient. So there's a couple different methods. Again, our most important thing is protecting the good lung from the bleeding lung. So you often want to separate them. One method is to main stem intubate the non-bleeding lung. Your cuff of your ET tube is going to protect that lung from any aspirated blood. The second is a double lumen tube, and I'll show you some pictures. And the third is something called an endobronchial blocker, which I'll show you as well. So when we think about this, one method, okay, is this is just your regular ET tube coming down your trachea. This is your carina here. And when we're looking at this, we're really kind of like looking at this cuff. And if you left main stem intubate somebody, you can just singly ventilate that left lung. What then happens to the bleeding right lung? We're letting it go. It's not going to participate in gas exchange. We're letting blood collect there. And at this moment, our priority is this is a patient who is about to asphyxiate, and you are trying to protect as much of the good lung as you can so that they can be oxygenated and ventilated until something definitive can be done about the bleeding. Okay, so that's one option. Why is it good? Because we all have ET tubes available. It's easy to stick an ET tube in too far. Usually you need to use bronch guidance to make sure you actually get into the main stem you're aiming for, but it's something that is easily available. The next option, and I don't know if this is hard to see or not, but this is called a double lumen ET tube. I'm not sure how many of you guys have seen this. If you've been in the OR ever, whether in med school, seeing any kind of thoracic surgery, you might have seen this. It's pretty routine if you're getting a VATS or something else to have a double lumen tube. And the reason for that is it allows the anesthesiologist to actually have separate ventilation for each lung. So if a lung needs to go down during a VATS, they can collapse one lung and ventilate the other lung. So a double lumen tube has two cuffs, as you can see here, and the two tubes, one is longer. So one tube will go into the main stem. In this scenario, it's going into the left main stem, which is the bleeding lung. That cuff prevents blood from coming out of the left main stem. And then the shorter tube and the second cuff that's in the trachea helps to ventilate the right lung. And so you can separate your lungs this way. So in case you're not sure, for example, like you see blood on both sides, you're not sure which side is the actively bleeding side, this way you can separate them from the start while you sort that out. And then the third option, something called an endobronchial blocker. This is just a regular ET tube in the trachea, but we basically have something, it's called a Fogarty balloon. So think of it as like the balloon on a swan, and you basically put it down the ET tube, you open up that balloon and you block the bleeding lung. So again, you're just blocking the lung that's bleeding in order to protect and oxygenate and ventilate the good lung. So these are some of the options that we think about when we're thinking about airway control. This is the double lumen tube. And this is sort of how we have to think about the endobronchial blocker, because we have both a bronch to help guide us, and the blocker itself is separate from the ET tube. So what do we need to know about all of this? Well, the main thing is they're really hard to keep in place, especially if your patient is moving. So it's really common, for example, if you put something down the right side and you right main stem intubate somebody, or you use a double lumen ET tube but have the long portion in the right side, the right upper lobe comes off so early that you essentially block it. So you often will be obstructing the right upper lobe in any patient that you're intubating on that side. It's really, really common to malposition these, and even if you position it correctly when it's first placed, tube displacement is also common. So up to a third will then get displaced after. So these patients essentially need to be in deep sedation and typically paralyzed, really just to prevent dislodgement. Are endobronchial blockers any different? Not really. They also unfortunately move pretty easily, and they're often just meant to be temporizing while you look for a definitive solution. So dislodgement is even more common than with a double lumen tube. And, again, you have to often paralyze these patients. So really tough, all of these decisions, but important to have anesthesia in the room and discuss all of these when you're thinking about the patient. But for that acutely unconscious patient, when you walk in the room, most critical care and anesthesiologist is going to go to their regular ET tube and main stem intubate the side that looks like it's not bleeding, because that is what's most immediately available. What can you do if you walk in, you go see this patient, they're actually awake, they're protecting their airway, but they are coughing up a lot of blood. So what can you do immediately? You can ask them to lie in a lateral D cube with their bleeding lung down. What are you doing there? You're just using gravity. Gravity to help keep the blood in the side that is down and prevent it from crossing over the carina into the good lung. So that's immediate. If you know which side the blood is coming from, lateral decubitus positioning, make them NPO, and consider the best and safest approach to secure the airway. You're not going to delay. So this is, you need to call anesthesia and critical care right away to be involved. And often these are patients where they look great, they're talking to you, but they're bleeding so much that we don't wait to intubate them. It's a lot safer to intubate them when that good lung is still good than waiting until they're actually in respiratory distress, because very often in life-threatening hemoptysis, at that point, they've already lost so much of their lung that you may not be able to oxygenate them. All right. I'll pause there because I know that is a lot more about airways than you guys probably normally hear about. But I think it's important to recognize, so when you hear these discussions happening, at a higher level, that you understand why everyone's discussing all of these different tools. So the next thing is to think about vent management. So these are patients who are often going to need a high FiO2 and a high P. Double lumen tubes are fascinating because you actually can attach each end of the tube to a different ventilator. So you can have two ventilators going, one for each lung. They can be synchronous or asynchronous depending on what's going on with each lung. And usually in these patients, we are choosing lung protective vent settings, so keeping the tidal volume low. In terms of single lumen intubation, or when you use an endobronchial blocker, I would think of those patients as patients where you are only ventilating one lung. What does that mean? Well, if you have single lung ventilation, you need a lower tidal volume, right? Because you're only ventilating one lung. So these are patients where we often choose pressure control as a ventilatory mode, and that's mainly to prevent overdistension of the normal lung. If you just give these patients their standard tidal volume of 6 cc's per kilo, you're going to be putting it all into one lung and potentially leading to barotrauma. So there's a question, if you're not sure which lung is bleeding, is it more harmful to have the person lay on his side and just ask them to stay upright or neutral? Yeah, so if you're not sure which side is bleeding, then don't worry about putting them in decubitus. I would just have them sit up. That's absolutely right. So it's only the patients where you have a clear idea, like they already have some imaging, they have a cavity on one side, or, a pneumonia on one side or something like that, and it's obvious. All right, so last in our ABCs are our hemodynamics. So remember, we talked about in these patients, they typically are not exsanguinating. That doesn't mean that they don't need to be resuscitated. Very often they might need that. They may also need a reversal of anticoagulation or coagulopathies or thrombocytopenia. So you need to think about good IV access. This is not any different than any other bleeding patient, right? So you guys know that we want, if we're using peripheral IVs, we want large peripheral IVs. Why? Because you can get blood products in faster, right? So I know we absolutely never can find an orange or a gray anywhere on the floors ever, and we rarely can find a green. But, these are patients, you don't want a 20 gauge and a 22 gauge peripheral IVs, you want something big. If they're unconscious and this is a code or an RRT, think about putting in an IO, which will be fast and give you great access. And if you have time, an introducer kit is going to also give you great access. So sorry, just answering another question in terms of minute ventilation. So by giving a lower tidal volume, so you can provide enough minute ventilation by ventilating one lung. So when you think about, we have patients who get pneumonectomies for cancers or other things all the time, and they do just fine, and they don't always even need oxygen. We luckily, in normal healthy lungs, have such room for expanding our ventilatory capacity that if the single lung that is a good lung is a normal lung, you should be able to provide enough minute ventilation, but you might have to do it by increasing the respiratory rate in order to keep the tidal volume stable. So absolutely, it's possible. Now, on the other hand, if you're talking about a patient who has severe chronic lung disease like end-stage COPD, and their good lung is unfortunately not a normal lung, then yeah, that's going to pose a challenge. And unfortunately, again, those would be patients you would think about early. Do I need to protect this patient early before I lose more of their lung to blood? Okay, I think I covered the hemodynamics. All right, back to night float. So again, type in the chat if you can. So you find out that this patient is a 50-year-old man with current tobacco use who's admitted for pneumonia. He was admitted a day ago, was started on ceftriaxone azithromycin. He's requiring 2 liters by nasal cannula, and his SATs have remained stable at 96%. He's in no respiratory distress and is hemodynamically stable when you go to see him. He does show you a cup with about 3 tablespoons of bright red blood, which he's coughed up over the last hour. He had a productive cough with yellow sputum and streaks of blood for a few days before all this started. And he's on sub-Q heparin for DVT prophylaxis, not on any antiplatelets. His chest x-ray from admission shows a right middle lobe pneumonia. So in this patient, what do you guys think are the most likely etiologies for his hemoptysis that you're thinking about right now? And type them in or say them out loud, whichever you prefer. Okay, so infection, absolutely. Yeah, so what type of infection? So instead of just a regular pneumonia, a necrotizing pneumonia, absolutely. So could it be MRSA, Klebsiella, a pneumonia that is necrotizing leading to bleeding? Absolutely. Okay, malignancy, awesome. So is this somebody who maybe has an endobronchial malignancy, and this is actually a post-obstructive pneumonia? We just can't see that on the chest x-ray. So really important to think about. Agree, anticoagulation is a lot less likely to be the sole cause given it's just sub-Q heparin. And PE, okay, excellent other thought. Right, could this actually be, maybe the pneumonia is actually like a wedge infarct or something, and this is really a PE that has been missed. So important to think about all of those things. So what data is most important for you to gather that night? Remember, it's 2 a.m., you've gone to see the patient. What do you feel like you need to know right then to make sure the patient is stable and to decide whether or not you think critical care needs to be involved? So again, type in the chat. Okay, so some labs. Yeah, you want to see is it CBC. So presumably he had normal platelets on admission, but that might have changed. You want to know if his H&H are stable. You want to know if there's any changes on his x-ray, or is it still just that right middle lobe pneumonia? VBG, excellent, just to get a sense of, is he actually still ventilating okay? And mental status, great. Yeah, so is he actually protecting his airway? But remember, we talked a little bit about if he is a conscious patient but has a lot of blood, you might still worry and want to monitor him more closely. And so just being on a floor may not be enough. This might be a patient, even though he seems totally stable, he might be somebody you need to monitor in ICU overnight because of the quantity of blood. So what is 3 tablespoons of blood? It's like about a 30 cc's or so, so not quite 100 cc's, you know, like it's not kind of meeting our criteria yet, at least within an hour, right? But this is just an hour. So if you watch him for the next 4 hours and he continues to have 3 to 4 tablespoons, he's going to have 100 cc's of blood within a few hours, right? And he's going to meet criteria for somebody who falls within the realm of having life-threatening hemoptysis. So this is somebody who, even though his mental status is okay, whatever other information you find, you might still want to call critical care and say, hey, I have this patient. He had streaks of blood, but now he has frank hemoptysis, and I'm afraid that nursing on the floor isn't going to be able to monitor him closely enough, you know, for us to know what's going on. Other things, so definitely a chest x-ray, but this patient, if his chest x-ray is stable and you want more information, this might be a great time to get a CAT scan, right? Try to kind of see what's going on underneath all of that. Are you missing a cancer? Do you actually see necrosis on the CAT scan? So that could really be helpful. Yeah, and whether it's a CTA to rule out a PE or not, that's a great question. So kind of looking at, you know, does he have any other risk factors for this to be a PE is going to be important. So great. Awesome job. So gathering supporting data. So I think you guys touched on a lot of this. Thinking more broadly, I didn't give any real history for this patient, but you just want to run through and make sure you're not missing any risk factors or comorbidities that might make you think of other diseases, right? So vasculitis, collagen vascular disease, those are things that can lead to both cavitary disease in some cases, like ankylosing, but also to alveolar hemorrhage. So diffuse alveolar hemorrhage, which you can see in lupus and some of the other collagen vascular diseases. So you want to do a screen and see if that's something, that he has known or that for any reason should be suspected. Does he have any underlying chronic pulmonary cardiac disease that puts him at higher risk? Does he have end-stage renal disease? So he may have a normal platelet count, but maybe is uremic and those platelets are uremic. That might be something you can intervene on. In terms of his risk for lung cancer, so we mentioned that as a possibility. He does use tobacco. We don't know if he has a history of COPD or any other malignancy, but those are things you would want to think about. Risk for HIV/AIDS, any history of bronchiectasis. We know he has an infection, but risk factors for TB or cavitary disease. And then has he had any recent procedure? So that's sort of broadly some of the things you're going to gather from the history. Medications, you want to know about antiplatelets, anticoagulants, and NSAIDs. In terms of labs, so CBC, renal function, coags. And then depending on the clinical picture, you might need cultures. That might include AFP cultures. Depends on the location of the pneumonia, if there is a cavity, and what risk factors might be. And you might choose to send a room workup, again, depending on if that's really on your differential after looking through his history and talking to him. And then finally, imaging, a chest x-ray is easy. Absolutely, you should do it that night. But in this patient, if his x-ray is stable, I might say this might be a good time to get a chest CT, as well as informing critical care that you're worried about this patient. So how does imaging help us? Chest x-ray in general can localize in about half of the patients. Those are typically going to be the patients that either have a very obvious malignancy or they have a focal pneumonia or cavitary disease. So those are the most common things that are going to localize on chest x-ray. Really, the majority of these patients are going to need further imaging and workup. And a question that always comes up is, who needs the emergent bronchoscopy? Well, it's important to realize where a CT is helpful and where a bronchoscopy is helpful. They're both complementary to offering a diagnosis. High-res CT is much better at identifying malignancy, bronchiectasis, aspergillomas, AVMs. So there's really a wide differential you can cover with a CAT scan. Bronchoscopy can definitely identify endobronchial lesions, but it's not going to tell you if a patient has, a big peripheral lung mass that does not actually go into the airway. So what bronch does allow is a path diagnosis. I would say in the vast majority of patients, if they're stable, we typically start with a CAT scan. And if there is a big lung mass, then we think about a bronchoscopy, both for diagnosis and potentially even for interventional treatment, depending on what we see. And I'll talk about that a little more. The only other time that we may start with a bronch first is for the patient who's unstable, where we don't think they can travel down to the CAT scanner and we want to do a bedside procedure. Doing a bronch can be helpful. The second is when somebody has diffuse disease. So let's say somebody has bilateral bronchiectasis. It's not clear on the CAT scan what is bleeding. You might need a bronchoscopy to identify which side is actually the side that's bleeding. And often in these patients, we're doing both. Question is about a CTA or high-res CT. That's a great question. So the high-res CT can be with or without contrast. So it is important, to get that for malignancy bronchiectasis in particular. A regular CT will identify aspergillomas. If something like AVMs is on your differential versus the PE, then it's not really a CTA because you have to time it for what you're looking for. So if you are worried about a PE, then you would get a CTPA the way you normally would to rule out a PE. But if you are suspicious about a lesion that could be an AVM, then you actually have to order your CAT scan in a different way. You have to tell radiology you want it timed for an AVM. So it does depend a little bit in terms of contrast. If you're worried about malignancy malignancy, we often do like contrast. Again, that is different timed. It's time for the mediastinum for us to look for lymph nodes, but it's not always necessary right at the start, especially if you're just trying to get something quickly in the middle of the night. So this kind of leads us into, well, how do we control this bleeding? And it's really important to realize that this is all multidisciplinary. So, you know, a patient who comes in like this, we are involving anesthesia, IR, and thoracic surgery, and pulmonary all together at the same time. And we're all discussing what the best plan might be going forward. Just to kind of talk a bit about the different possibilities, there are bronchoscopic methods to control airway bleeding. This can be done with the regular flexible bronch that we all do, but sometimes it needs to be a rigid bronch, which is a stiff bronch that our interventional pulmonologists and thoracic surgeons are the only ones who use, and that's typically done in the OR. There's a lot of different methods to stop bleeding that you see in the airway. So if you think about a patient who, you know, might just have bleeding after we do a transbronchial biopsy in the bronch suite, one of the things we do immediately is we use our bronch as a blocker to prevent blood from coming out of that lobe. And we irrigate with cold saline and sometimes epinephrine to stop bleeding. And in majority of cases, bleeding will stop from that. So that's something that we do immediately when our bronch is already in. But there are a ton of other things that have been looked at. These are really specific to patients who have airway lesions that are bleeding. So endobronchial cancers, tumors that are there that you can see. And there's topical procoagulants like TXA, there's endobronchial tamponade, there's electrocautery, cryo, laser, APC. So a ton of different ways that you can essentially, freeze or shock or cauterize something that you visibly see bleeding. But for most of those, we will involve the interventional pulmonologist or thoracic surgery to perform that higher level service. TXA inhalation, I think, is a really interesting new area that we've seen a lot of benefit in small studies. There's really just one RCT a few years ago. It was done in patients that actually had non-massive hemoptysis, but our patient at the moment with 3 tablespoons of blood might meet that criteria and would have been included. So it's a small N, 47 patients, and they got TXA inhalation versus placebo. And really TXA inhalation, you can see here, that 100% of the patients stopped bleeding with TXA versus only 50% with placebo that were self-limited. And when you look at kind of the rate of how the amount of blood that was expectorated, how that changed, it immediately improved within the first 2 days of those who were getting TXA inhalation. So it led to not just faster resolution, but shorter hospital stay, fewer invasive interventions, and even reduced recurrence up to a year out in this placebo study. There are a number of case series as well in a lot of different populations. I'll point out one in particular, which is in cystic fibrosis. These are patients who come in very frequently. Hemoptysis is a common complication from their bronchiectasis, and many of them need frequent interventions to stop hemoptysis. And so TXA inhalation has actually entered in as a great opportunity to kind of prevent invasive interventions in this population of patients. So we've used it quite a few times here at Beth Israel, where we have a cystic fibrosis center. So we get a number of patients like this, and really seen great results. So similarly, case series in CF patients has shown that TXA can reduce quantity of blood and faster time to resolution of hemoptysis. So really a cool new thing to consider in some of them. The mainstay that we consider is bronchial artery embolization. This is obviously done by interventional radiology. It's only done for those 90% of cases that are in the bronchial arteries. They don't embolize the pulmonary arteries. So it's been reported as initially successful in a pretty high number, up to 99%. These are all case series. But when you look at a meta-analysis of all of this, you can see super high rates of resolution early on, but a lot of these patients actually do recur once you go 1 to 2 to 3 years out. So even though there's early success, there is high recurrence after bronchial artery embolization. This is still sort of our first go-to because it's much less invasive, obviously, than surgery. And ultimately, surgery, is tough. Early evaluation is important. Many of our thoracic surgeons, they actually want to be in the IR suite when BAE is being attempted because they want to be able to see the vascular anatomy. And that's really, important for them to kind of understand what's going on. And then we have to look at what the diagnosis is in the patient and balance the underlying comorbidities with really their ability to undergo lung resection. So, a patient I had who had a very rare it was a very rare lymphoma, but it was a vascular lymphoma. And what was bleeding was actually at the hilum. And he actually needed a pneumonectomy in order to control bleeding. But he was 30. His other lung was 100% normal. And the bleeding couldn't have been controlled any other way. So that was a patient who could both tolerate a pneumonectomy and really had no other choice to control bleeding. So it was a great candidate for surgery. Some of our patients that we're thinking about are patients who are older, often have advanced COPD, and they present with a lung malignancy that is not curable, and they start to bleed from that. And these are patients who may not even tolerate a lobectomy, let alone a pneumonectomy, depending on what they needed. And so patients like this are ones where we really try, BAE first, bronchial artery embolization, which they can hopefully tolerate, and hopefully buys time for, definitive treatment that might include chemo or radiation, depending on what the underlying etiology might be. And then lastly, unfortunately, really everything that's published, for these patients that do get surgical resections they're just their case reports and case series. So it's really difficult to interpret any of that outcome data. So just a reminder, massive hemoptysis requires a multidisciplinary plan. So we are calling all these services to really be involved. All right, I'm going to pause again with a tough case here. So 72-year-old man seen for hemoptysis, 14 years of rheumatoid arthritis, and he was previously on Plaquenil, methotrexate, gold, penicillamine, etanercept. He's taking now adalimumab and NSAID, has a history of smoking, but quit for 10 years, had some exposure to asbestos, has long-standing bilateral pleural plaques, upper lobe nodules, has an ILD that looks like UIP pattern. And a lot of this is thought to be lung disease or ILD secondary to his rheumatoid arthritis. So a rich history of potential causes of hemoptysis. So he's noticed streaky hemoptysis with yellowish sputum about 5 months ago. It cleared and then recurred. Doesn't have any fevers, chills, weight loss. He has some neck pain that's due to his RA. His exam really is not that notable. His spirometry shows he has some mild reduction in his flows. And you see a CT here, which I will point out to you, this big, huge cavity that looks like it has something filling. This is an aspergilloma in a chronic cavity. And he was already bronched. It just showed some old blood here on the left side, nothing active, nothing endobronchial. So what would you guys think about doing next out of these choices? Feel free to put them in the chat. Okay, so we got a lot of C's so far. Anyone else? Any other thoughts? Everybody agrees with Nor and Christopher then? Fantastic. Okay, we got one for a B. Thank you. So awesome. Yeah, no, you guys are right. This is surgical resection. So one would think about bronchial artery embolization, but it's been shown for aspergillomas to have a really high recurrence rate. If he was really unstable, you would do it to stabilize him and buy you time so you didn't have to do an urgent surgery. But since he's relatively stable and his lung function actually looks pretty good, he probably can have this resected, and that is the most definitive treatment for an aspergilloma that's bleeding, because it's highly likely to recur with bronchial artery embolization. Whether or not you should treat with itraconazole, it's great. There are studies out there looking at treating, but mostly it's for people who have parenchymal disease, so a surrounding infiltrate that you think is related to the aspergillosis. All right, awesome. All right, so a little segue here. We've been talking a lot about life-threatening hemoptysis, but most of what you're going to see is non-life-threatening. So it's the same principles. The difference is that you have time, right? So you don't have to do everything in the first few minutes of seeing your patient. You have time to think. So the first thing you're going to do in those patients is gather all your data, your history, your labs, your chest x-ray. From that, is there a clear diagnosis? So in this patient, for example, there is a clear diagnosis that he has a pneumonia, but you're concerned about underlying cancer, but there's a clear diagnosis. Okay, well, you might choose to target the treatment and see if that leads to resolution of the hemoptysis. So if you think it's from a pneumonia, you might say, let's treat for a week of antibiotics, see how he does. If it all resolves, you know, maybe that's all he needed. But in the patient who has risk factors for lung cancer because of a smoking history, COPD, other malignancies, you're going to want to get a CT. And for patients who you think have risk factors for a PE, you're going to want to get a PE study. So in this patient with the risk factors he has, you could make an argument that maybe you're worried about a PE, but I would say any CT chest, just looking for lung cancer is what's going to be the most important. What about a patient you see where it just seems like acute bronchitis? You know, they give you the classic signs, URI, intractable cough, coming up with some productive phlegm, nothing else that's concerning at all. Their chest x-ray is normal, their labs are normal. So these are patients that should have self-limited hemoptysis. So if you treat them, if they typically it's viral, they don't need antibiotics, if they need inhalers because there's an underlying airways issue, but it should resolve quickly in those patients. If it recurs, then you may need to really consider working them up further with a CT and eventually a bronchoscopy. And again, if they have risk factors for lung cancer, you're going to get a CT anyway with this first episode. What if there's no obvious etiology? All the labs are normal, x-ray is normal. They really don't give you a great picture for bronchitis, you know, no URI symptoms or anything else. This is a patient that you're probably going to have to look a little more deeply. So you're probably going to end up with a CT. You might end up doing a room workup, trying to figure out other causes. And remember, your chest x-ray is not going to find everything. So your chest x-ray might look kind of normal, but then your CT chest might show you the patient has underlying bronchiectasis, or the patient has an underlying lesion that looks like it could be an AVM. So you might then, you know, kind of from there, tailor what the next steps in your management are going to be. But ultimately, everything is pretty much the same. It's just that you have time to do this. If you see a patient in clinic, you know, who, you know, uses tobacco, has a diagnosis of COPD, and they're coming to you with, you know, a chronic cough that's a little worse, and they have streaks of hemoptysis in their normally yellow sputum, that's a patient that you can treat for their bronchitis and for their COPD and kind of assess, if they haven't already gotten a low-dose CT, whether they need that workup for lung cancer, but otherwise, you know, hopefully it should just resolve. So you have time to do that. You know, you don't have to send them to the ER that day, you know, to get a CAT scan. You know, you have time to do that over several weeks. So to conclude some of the main points, most importantly, when you get a call, is quantify the amount of hemoptysis and evaluate ABCs to determine the urgency of your workup. Then you're going to spend some time gathering all the data that is available to narrow your differential and apply really a multidisciplinary approach to management. And remember to just consider a CT in patients who have non-life-threatening hemoptysis, but risk factors for lung malignancy, PE, or if they have recurrent hemoptysis. All right, so I will pause there. Did I miss any questions by any chance?
Thank you so much, Dr. Patrawalla. Yes, if anyone has any questions right now, you feel free to unmute yourselves or put it in the chat.